Akak, bukan ni tak payah komputer ni. Yang kita orang upload lah. Betul, macam banyak sangat. Nanti kan daripada ni. Okay, let's see. Apa macam ni? Upload log. Including verify you have the necessary permission to upload the file.
Next week.
Your exams.
No, final year next week.
Oh, final years. Oh, June.
Yeah, that's why tadi kita ada problem.
Jadi kan.
Orang kan tak sudah saya.
Nobody wants to go to the air.
Sahaja dah tu.
Hi, Prof, how are you?
Okay, let's see.
So sudden change. And just
Bidan terjun S. Ganti Roslinda.
Welcoming remarks.
Oh, just say hi, welcome.
And bye, Prof. There's one important
Enjoy.
message in there regarding yang kenapa? Kalau kita gini, kita letak gini tak boleh. Oh. Ada
Thanks,
benda
so.
saya dekat dalam. Kalau kita let's say
Sebulan juga kan, he was
kita orang pergi.
Yeah.
start that.
Jadi tu namanya.
Tak payah.
Tak ada sebulan. Yang fall sekarang.
Okay.
2 hari, 3 hari on call. Kakak.
Yeah. Oh, I have more cake for you. Ada cake lagi.
Cik yang itu.
Baru lagi.
Dekat ni, nanti Prof dekat tempat dia je.
Yeah.
So datang sini.
Semi formal, not really formal.
I can see.
Yeah, you can see. Next.
Aida,
Wherever you want.
Assistant.
Yeah. Yeah. Boleh lah, hantar banyak kan.
Cik dah ada.
Rembek ni yang I drive.
Less aktif lah sekarang.
Rasa macam tak berapa nampak dia. Selalu kalau lalu petang kan dia.
Ada pokok tu.
Yes, sir. Oh, why are you giving it to me? I'm not the one who's going to sleep most of the time. Boleh.
KMC tu nak cakap dengan Prof tadi. KMC tu nak mention tu.
Are you the MC?
Yang Cardiologist.
Senior.
Masuklah kau. You have no plans.
You join call when?
Oh, you
They
have
said,
plans.
anyone key to get the state aspect now.
Tu
It's actually make no difference.
You can just read.
Because we service.
Somehow for him it makes a difference. I don't know why. It's really keen to do that.
That's what I got already.
He will come up and suspect.
Sama.
But I have ketat. Okay, for me, I want to respect.
We are opening up masters program kan, so we need to
I know.
Ni sekarang masih lagi memujuk Amira.
Punya slack ke?
Yeah, she's both. She's the first batch.
Memang corporate. Tak ada. Ya. Nampak corporate lah. Tak adalah just
Video pun buat sendiri.
nampaklah corporate dia.
Definitely dia nak keep in touch.
Put me. Then you say.
But makes no difference.
So recall.
Sebab kalau
Oh, it's getting that now. It's suspect.
Academic.
Almost 10 years ago.
oh yeah, well you get teaching allowance.
Yeah.
9 years.
At the beginning will be 100 dirham.
You are
Not
there.
genuine wise.
Because it follows your last.
Yeah, he was here.
You jump into the lecture, you go straight to 51 yet.
Maybe we come back here.
Some difference, but I got
So this word is just from
what they say, because what is the money doing?
Everything is money nowadays. We don't intentionally, but inadvertently it's all about money.
Pandai yang
That's what you need.
Capek bang. Orang menakutnya. Dia nak perasaan dia. Kau ni tak cakap dia orang minta.
Assalamualaikum and good afternoon to all.
So for those who have just arrived and the participants, I would like to ask you to just scan the QR code on the, just before you enter this room there's actually a piece of paper with the QR code there so that you can get your e-certificates. So feel free to scan the QR code.
Can you just say our chairman maybe one thing is
assurance for the chairman and chairman of the chairman of
and
depends which one you want to do. You know, this is two souls to be the chairman.
Submissions.
By the way.
Kita tak ingat jalan dia dah
Kita ingat nak kom ke mana? Adanya.
She's the director of the this assisting the business.
Yeah, that is quite good. Okay.
Please. क्या करता है?
So I've got a few postgraduate students.
Yes.
Of course, lecturers as well.
Right.
As you are aware.
Okay. So maybe we have a bit of ta'aruf first before we start? Or-
Sure.
Yeah.
Can we start? Can we start now?
Yeah, we might as well. We might as well.
Bismillahirrahmanirrahim. So thank you to the all participants and attendees of our workshop today. So just a quick reminder for those of you who have not registered yet, just scan the QR code located at the door and at the pillar next to the entrance to this conference room so they can get your e-certificates. All right, so everything now is electronic. You don't need paper certificates anymore. All right, so just a bit of introduction. We have Professor Dr. Sirajuddin Muhammad Salam as a professor in Kuliah of Medicine and also as the head of the scientific committee of the Medical Research Symposium. And our honorable speaker for today, Dr. Azarisman Shah Muhammad Shah is a senior consultant cardiologist from KMI Kuantan Medical Center, and to all the professors, associate professors, lecturers, postgraduate students. I can see quite a few from the several different departments. Assalamu alaikum wa rahmatullahi wa barakatuh, and good afternoon to all. So let's begin with Bismillahirrahmanirrahim. So I'm Dr. Hosni. I'll be your moderator for today. I'll just moderate some of this, a bit of this event today. And on behalf of the organizing committee, I would like to welcome all of you to this workshop today entitled Clinical Insights to Journal Articles, Writing Effective Medical Case Reports. And this is organized by the Office of the Responsible Research and Innovation, Kuliah of Medicine. So hopefully, at the end of this workshop, all participants can go home with some practical guidance on writing effective case reports, and hopefully you can get them published in possibly some of the leading journals, as Dr. Azarisman Shah has done before. So just before we start off, I believe I'd like to invite to the floor Professor Dr. Sirajuddin Muhammad Salam as the head of the scientific committee of the upcoming Medical Research Symposium to give some opening remarks to all of us. Please welcome.
Thank you. Assalamu alaikum and good afternoon to all of you. First of all, I would like to welcome all of you to our case report writing workshop. I am thrilled to see so many enthusiastic professionals ready to contribute to the pool of the medical knowledge through your case reports. Okay. First and foremost, I want to take a moment to appreciate our esteemed speaker, former professor of Kuliah of Medicine, Dr. Azarisman Shah Muhammad Shah, the senior consultant cardiologist, and 2 times our former deputy dean of academic Kuliah of Medicine. Okay, for being here today, his expertise and then experience are invaluable, and we are fortunate to have him to share his insights with us. Okay, So dear doctors, we hope that through this session, you will gain the skills and confidence needed to craft the compelling case reports. I encourage you to approach this task with confidence, knowing that your work can make a significant impact. I have received the assurance from our the head of research Kuliah of Medicine and the chairman of the MSPP MRS 2024, Associate Professor Dr. Rusulina, that your case report submissions are highly valued. Okay, our team will provide the constructive feedback to increase the likelihood of your case reports being accepted through this workshop. On top of that, all accepted abstracts will be published in the Medicine and Health Journal. Okay, so let's get started, and I look forward to seeing your impressive case reports. Okay, that once again, I welcome you all and then a fruitful session. So I conclude it with a thank you very much. Okay, Assalamu alaikum.
So, thank you, Prof. Siraj, for the welcome remarks just now. So just for information, today's workshop will be divided into two separate sessions. The first session will be a talk, I believe a short talk by Dr. Azarisman, followed by some hands-on session after that. So I believe that all of you have brought forward some case reports or papers that you want to get input and feedback from Dr. Azarisman. So we can get those ready later on. And hopefully we can end our event today at 4:30 p.m. inshallah. Or even sooner, depends on how far we get along here. So I think I'm just a really quick introduction. I've known Dr. Azarisman as Prof. Azarisman. You know what they say, once a teacher, always a teacher. So once a prof, always a prof, isn't it? So he studied his medical degree in University of Adelaide in Australia, and then his master's in internal medicine in UKM, and then he did his cardiologist specialty training, and he didn't stop there. He furthered into a PhD as well, going back to University of Adelaide, Australia. So I believe that he is more than qualified to talk about this, and I believe he has published numerous papers as well in multiple journals across his career here. And as Prof. Siraj has mentioned before, he was professor in medicine here in Kuliah of Medicine. He was also as the deputy dean of academic and internationalization here. So without further ado, I'll give the floor to Dr. Azarisman to start the session. I think we're going to start off with some introduction as well. So without further ado, please, Dr. Azarisman.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon for everyone who are here. Very enthusiastically. Okay. I'm assuming that you are enthusiastic, okay? So that's number one. Number two is I'd like to thank Dr. Siraj, Prof. Siraj, Barakallahu Feek. Thank you. And Dr. Husni for a very gracious and kind introduction. Yes, I have walked these halls before, many years ago, many moons ago. Not that many moons ago, okay? It was 18 years from 2001 to 2019. So I have been here for quite a long time. I feel old already. So anyway, before we start, why don't we get a gist of the sort of audience that we have here? Let's maybe go around the table and maybe you can tell us about who you are and where you're from, which kuliah are you from. Don't tell me about where your school is and your kampung is. Which kuliah you're from and what department. Maybe that will then give me an idea, a mind setting as to the tone and the clinical sort of relevance that I can relate to this afternoon. Maybe we can start from the right. My God, I don't know this woman.
Assalamualaikum and good afternoon. My name is Dr. Aida. I'm an emergency physician from Emergency Medicine, Kuliah Medicine. I also don't know.
Assalamualaikum, I'm Azarisman from Family Medicine Department. Assalamualaikum, I'm Fatiha from Family Medicine Department.
My name is Aisha Mohd.
My name is Ahmad Hafizuddin bin Johari. I'm from Department ENT. Assalamualaikum, I'm Afiful Hadi from ENT Department. Good afternoon, I'm Dr. Lim. I'm from ENT Department.
Assalamualaikum. My name is Cardiologist from Department of ENT. Assalamualaikum. My name is Roshani.
Usually I brought along with
I'm
me.
student from ENT Department. Assalamualaikum. I'm Sarah from rheumatologist from the Dental Department. Young lecturer department. Assalamualaikum. My name is Samira, lecturer from the Cardiology Department.
Assalamualaikum. Azarisman from Kuliah Pharmacy. Clinical Pharmacy Practice.
Assalamualaikum. My name is Azarisman. I'm from ENT Department.
Assalamualaikum. I'm Mohd Ismail from Emergency Department.
Assalamualaikum warahmatullahi wabarakatuh. I'm Nazrul from Emergency Department. The youngest of all.
Youngest. Okay.
Assalamualaikum. Sorry, indeed. Nama Nurul Hikmah Maino, ONG Department. Assalamualaikum. Good afternoon. I'm Rainis from ONG Department as well.
So, welcome everyone. ومرحبا بكم. So ONG, ENT, Emergency Department. So ENT, you brought your old friends.
No, not all. Still a lot more there left behind.
And family medicine. Okay, good. Alhamdulillah. So I really appreciate your presence here. Now, what that tells me is that you're very interested to know about how to publish. And the second thing is, now I presume all of you are young lecturers, yeah? All of you has just got your, your masters and clinical masters, or some of you are still doing your masters.
Still waiting.
Some of you are still doing. Okay, good. Look, when we talk about case reports, the good thing about the concept that it's done now is, and the way your masters is structured nowadays, is that you must always come up with case reports. Am I right? Yeah. During my time, when I was doing masters, it was years ago, I was supposed to come up a case report for every attachment I did. And that was 8 total attachments in internal medicine, inclusive of, gastroenterology, cardiology, neurology, and for every unit or department that I was attached to, I had to come up with one case report. And so what ended up happening was that I had a whole book, which was my master's thesis, and another book, which was my collection of case reports. We had to put all of them up. Okay, and so this was UKM. That back then, they were very tribal, and we had to endure all that samsara for all that. But of that, I actually published 4 out of 8. Okay, and when I say publish 4 out of 8, I don't mean local publications, I mean international publications. And this is the time, especially when you are doing masters, this is the time for you to publish papers, because this is the only place in a university setting where you will have senior professors coming and sharing their points of view and thoughts and telling you whether your papers and your write-ups are good enough for publication. This is the time. There is no other time. When you're out and about there, out in the periphery, working and practicing as a clinician, yes, you're the boss, but you do not have any opportunity at all to be able to, number one, analyze, comment, and categorize the cases that you see as being either usual or rare or exceptional. And of course, the papers that you present as case reports are papers that need to be extraordinary or exceptional, because there are thousands of case reports. Okay, so let's just start. So just a brief introduction. Again, I've been here for a long time already, 2001. I don't know whether you guys are out of school yet then. That was how long ago I was. And yes, 2001, I was actually one of 2 medical officers who were taken in as medical officers and not specialists. We were the first 2. The other one is now in Department of Surgery. I'll let you guess who that might be. Think about a person who might be around my age group, 37. Around my age group, and think about who that person might be We were the only two that were hired by Prof. Tahir as medical officers and not as doctor specialists. The only two back then. Okay, so this is a mystery. If you do get the person, you'll get a prize from me. Okay, all right. So it's been a long time since then. Now, how important is a case report? A case report is more important than your expert opinion. Okay, you look at the hierarchy. Your expert opinion count for 0. So out there in the periphery, in the hospitals, you as a head of department, as a senior consultant, as a senior professor in medicine, your word counts for 0. Why? Because number 1, it has not been published. Number 2, it has not been reviewed. Your thoughts, your opinions have not been reviewed. Your thoughts, your opinions are yours alone. Okay, and so therefore, as far as being an academic, and we are here all academics, as far as being academics, the case report is more important than any of our opinions. Okay, very important. So in order for you to be able to say what I'm saying is true, at the very least, you must produce a case report to show it. Okay, at the very least. Okay, but of course, if you've got a systematic review, if you've got an RCT, then far, far more ahead. Okay, and so therefore far more relevant what it is that you say. Otherwise, it's hearsay. Hearsay. A lot of hearsay in academic department. I've been through it all. Okay, so anyway, very important, case reports and case series. Now, why is it also important? Because this will be the bulk of your publication. You will not be going to be publishing, RCTs, systematic reviews, cohort studies. Although from what I heard, some of you have actually mastered the act of systematic review. Some in Department of Pediatrics, yeah, they've been doing very well. Assalamualaikum. Please come. They've been doing very well in terms of systematic review. Again, it's something that you can learn. It's not something that is, holy grail or beyond reach. It is something that you can learn. But let us start with something new first. Okay, something simple. Case reports, everyone. Family medicine, you see all units. You see all subspecialties, don't you? Emergency medicine, you see all subspecialties. You should publish in every one of them. You see a pediatric case, you publish. You see a geriatric case, you publish. You see a cardiac case, you publish, because you are the gatekeepers. You see them first. Family medicine out there in the periphery, and emergency medicine in the hospital setting. You're the gatekeepers. You then can identify instantly extraordinary cases. Okay? Now, I can say less about ONG, for example, or for ENT, because you are very subspecialized. But having said that, everyone gets delivered every day. Everyone gets an ONG problem and consult every day, and everyone gets an ENT consult around here every day, especially in the East Coast, because we've got this thing we call peer back. You know what it is? I'm sure you get that consult every day. Okay, peer. You know what peer is? It's a tick in your ear. Okay, and yes, they do crawl up your ears. Very itchy. Anyway, so let's go back. So the best teaching of medicine is that taught by the patient himself. So what a clinical case report really is you relaying to others how this case taught you to become a better doctor. Okay, and sometimes you fail, patient dies, or clinically complicated went wrong, and sometimes you succeed. And you succeed how? People would like to know how you succeed. Okay, so this is how you can tell and you can share with the world about the good work that you're doing. Okay, about the good work that you're doing. So, as I said, number 1, you're the expert. No one else is the expert. Anyone else here is going to believe me when I tell you PIRAS is the most common cause of ENT trauma in the world now? Anyone's going to believe me when I say that? No. Why? I'm a cardiologist. What the toot am I talking about ENT? Okay? Understand? So you are the experts. In ONG, in ENT, in family medicine, in emergency medicine, no one else is better than you at knowing what is important, what is exciting, what is extraordinary. Okay? And so therefore, you must, number 1, you have to have, a bit of self-confidence. In Arabic, it's called himma. A bit of self-confidence in yourself, in your ability, in your own knowledge. Okay, so that's number one. Number two, you are the one who also sees the routine, the interesting, the extraordinary, the exceptional on a daily basis. Okay, so you have the right to tell me what you're telling, what you're seeing, what you're experiencing is good or bad. So you are the one. So I'm not going to tell you as a senior professor, regardless of the fact that I've been here 18 years, regardless of the fact that I published many things, as an ENT specialist, as a family medicine specialist, as an ONG specialist, I'm not going to know anything about your field. It's your responsibility to tell me. Okay? So, therefore, the approach to case reports are, number one, exceptional case. Of course, that's number one. You see an exceptional case or a case exceptionally handled. Okay? Or a complication exceptionally handled. Exception meaning exquisite, out of the ordinary. Okay? An interesting aspect of a usual case. Sometimes it's a routine case, but something happened from that case which either caused a huge complication or resulted in a huge brouhaha around the clinical aspect, and therefore it then allows you to publish it. So an interesting aspect of a routine case, also very important. And when I say interesting aspect, atypical presentation, okay? For example, you can get, in the past, almost everyone who comes in with a cough, constitutional symptoms, emaciated, they're all TB. But nowadays, they can come in relatively healthy and well. And yet the only abnormality that we find on them is really backache and a spinal problem. Okay? Spinal TB is real. Okay? And we're the only ones who can publish it because Pahang is the TB center of Malaysia. Of Semenanjung Malaysia. Okay? Apart from Sabah and Sarawak. So you are the ones who can find these cases. Atypical presentation. Bystander involvement. Patient who comes in with two abnormalities or two pathologies. How common is that? Okay? Now, I'm sure you've all heard of the concept in medicine called Occam's razor. Have you heard that? Occam's razor is the statement in medicine which states that for everything that the patient complains of, it's all leading to only one diagnosis. There's no 2 or 3 different diagnoses. But believe you me, if you've been in medicine long enough, there's always a second thing. And that's what we call a bystander. Whether it impacts on the first case, on the pathology of the first primary case, that's a different story altogether. But there's always cases that involve 2 or more pathologies. And so therefore, never discount that. And that on its own is publishable. Okay? Bystander involvement. Severe or exceptional complication. Yes, you may be in trouble. You may not sleep for 2 nights because of your patients and handling your patients. But your inability to sleep can be translated into your ability to publish. Okay? And so therefore, take note of, exceptional cases. Exceptional difficulty in management of patients. Unusual treatment or response. People nowadays, especially in the East Coast, swear that if you drink water from, ubi kayu, you'll get cured from dengue. I have no idea whether that's true or not. Okay? But apparently, the stories are going around. And so therefore, if you're smart enough, if you're acute enough in your thinking, you can find out what it is. In ubi kayu, for example, broth water that can cause amelioration of symptoms in dengue. You might win, something in the future, just based on that. So do not discount, even traditional medication, despite the fact that we usually, scoff at people who come in with traditional treatment. You have, believe you me, 80% of our treatment comes from natural products. Okay? We're still using what? For malarial treatment. We're still using quinine for malarial treatment. How long ago was that? Okay. How long ago was that? That's still being used. Okay. Right. So an interesting image. That's the other thing. Now, if you want your case reports to have purchase and to have gloss or shine, the best way to get people's attention is a picture. As they say, a picture tells 1,000 stories. Okay? or a picture is equivalent to 1,000 words. Why? Because that single picture is able to evoke so many memories, experiences, clinical vignettes that play around in your mind by just a single picture, no matter how many words you put into it. So the best purchase for you, and when I say this, the best, I mean it the best. I have almost always published all of my papers as case reports with images. Almost always. Okay? So do not discount an image. Right. So that is my own experience. But how do I back up my experience? It's based also on published media. If you look at papers, for example, looking into how to publish, there are actually papers on how to publish case reports. And I advise you to look it up. And this is just one of them. And this is one of the recent ones, which I thought was very well written. And this is writing about the case report in a journal on urology. Can you imagine? Why on earth made this man think about publishing about case reports in Journal of Urology? Why shouldn't he publish in a paper on, in a journal on medical education, for example? Because your words have purchase if they are reviewed and accepted for publication, regardless what the publication is. Okay, maybe not manga or gila-gila. Okay, that one also has purchase, but they won't get you anywhere, right? So more importantly, case reports publication. And so this is one of them. Okay, this is one of them. So again, this is a more complete list of the things that you look for. Okay, unreported side effects, unusual side effect, adverse interactions, unexpected or unusual presentation of the disease, new associations, yeah, presentations, diagnosis, and management of new and emerging cases. Can you imagine how many people got published on the COVID? Can you imagine? Hundreds of publications on COVID, and you guys missed out. All you guys missed out. Family medicine, mashallah. Emergency medicine. ONG, I'm not sure whether you can publish this on COVID or not. I don't know. But you know, family medicine, emergency medicine, frontliners. Right? How many case reports you've missed? Okay. Unexpected event in the course of observing or treating a patient, and findings that shed new light on possible pathogenesis. Okay. So whenever you're thinking about a case report, keep a format in your mind. And the format that I usually keep to is, number one, have a catchy title. This is so cliche. Have a catchy title. No, look, have a field day, you know, about having the title. But later on, once you get reviewed, then your title will change to fit the actual publication and paper. But as you go on, as you start, have your own title and make it as catchy as possible. Make it as cringy as possible. Why not? Okay? Because that will be the crux of your publication and the reason why you want to publish it. Okay? Number two, avoid abbreviations. Okay? Do not put MLA and COVID and that sort of thing. Please do not. Okay? Assume your reviewers are all dull. Okay? They don't understand the whole thing. But by always means be concise, be specific, but try to be appealing at the same time. Okay? When I say keep to a format, all your case reports should be written up as a full-length case report, and that should be 1,500 to 2,000 words. Never write anything shorter. Okay? And that has to be a format. When you talk about 1,500 words, it's likely to have 5 paragraphs of 300 words each. Okay? 5 paragraphs, 1 introduction, okay, and 1 conclusion, 1 discussion. So you've got 2. So 1 is a clinical presentation, and number 3 is the treatment. So number 1, introduction. Number 2, case report or clinical presentation. Number 3, treatment or possible adverse drug reaction. Number 4, discussion. 5, conclusion. Very easy. So 5 paragraphs, 300 words each. If you feel like you've hit the wall and you can't write a single thing, at the very least, write the first paragraph, which is what? The clinical presentation. That's in front of you. That's in the folder. Okay? Come up with a very cliche or very cringy title just to get you excited, and then write up the case report. That's 300 words. Don't write 3,000 words on a case report. And that's when you start, going left, right, tangents, and then suddenly you realize you've run out of ideas, you don't want to write anymore. 300 words. So if you've got a problem, start with case report of the actual case. 300 words, first paragraph. And from there, believe me, everything will start rolling. Everything will start rolling. So how I write my case report, number one, I have a title, what I want to highlight about this case report, okay, about this case. Number one, have a title. Number two, I immediately write the case report. So the way I write, and Jamal knows this, Professor Jamal, your dean, knows this, because he acknowledges I do not write the way other people write. Other people write case report, abstract, introduction. Okay? When you get head banging at introduction, you don't complete the case report, and there goes. So you write what is more important first, case report. So write the case report first. Write about the patient, but limit yourself, 300 words. What is the most important points I want to put through in this case report about this patient or about this clinical scenario? Once you've started doing that, your introduction and your discussion agrees. Why? Because you already know what you want to write. Understand? So always start 300 words, first paragraph, case report. Okay, start that way. Number two, once you've done your case reports, your discussion and your introduction, even before you go for your discussion, write the abstract. Write the abstract. Okay? And the abstract, again, should be structured the way you structure your full 1,500 words. You structure it that way. So you've got introduction, discussion, or case report, and then conclusion. Okay? And how much can you write? 100 words each, or 50 words each. You can't write too much. In the end, you struggle trying to keep within the number. Believe me, you struggle to keep within the number. And always structure your abstract that way. Introduction, discussion, and then conclusion. And then after that, you tailor it according to the journal requirements. Some journals prefer it to be a single paragraph essay type. So do you structure it, you take out the key points or keywords. And then otherwise, you keep to that format. So always keep to a format so that you know you're going through something usual. Keep 3 to 5 authors. The one thing that I have learned to do when I've been publishing is I have always made friends. What do I mean? I always try to bring my friends into my case reports. I have published case reports with 10 different authors. They did zero, not even review the paper. Okay, but I have put them in because I'd like to be inclusive, number one. Number two, I'd also like to hear their opinion once I give the report out for them to have a look at. They might read, they might not read, but their opinions might count. And when you have as many co-authors as possible, try to make them as many in different fields as possible. Okay? I'm not asking you to be greedy and get all 5 from family medicine or all 5 from ENT. No, you must in any clinical case report when you have images, at the very least 1 radiographer or radiologist. At the very least 1 histopathologist or pathologist. Okay, and at the very least another subspecialty person who is co-involved in your clinical management of that patient. Okay, so at least have 3 to 5 different authors. Even if they would give you a single input, it helps because it also gets them involved with you and gets you involved with them. I have never written a case report 1 name, never. Never. Okay, so next 3 to 5 keywords. Again, as you're writing, think about the keywords that you'd like to put in as you're writing. And in the end, believe you me, if you have this format in your mind, okay, after the first paragraph of putting down your actual case report, everything will be auto-filled. Everything will be auto-filled. Okay, as you're going along. Okay, so prepare images. Like I said, images very important. They might not be chosen. They might not be viewed as relevant by your reviewers, but they are there to also direct your storytelling. Okay, because that tells you what comes first. Okay, non-invasive to invasive. Okay, that's how you relay your information from non-invasive to invasive, from single discipline to multidisciplinary. Okay, that's how you relay your story. You understand? Okay, and the same way you relay your story in your case report is the same way you relay it in terms of the images that you put up. Understand? Okay, simple, eh? Can you think of maybe 1 or 2 cases now in your mind that you already have 300 words? How many of you in your mind now have already got 1 or 2 cases, 300 words about that patient? Don't talk about anything else, just about the patient, 300 words. Come on. Come on, it's not 5 o'clock yet. Okay, so see, okay. So yeah, I'm sure you do. I'm sure you've got case reports. Yeah. All right. So again, that was my opinion, my own take, my own point of view, and my own experience. This is what formally it is. Okay, and you can find that in that paper, in that publication. You can look it up. What? This is not important in terms of giving you a whole list of what to do. It is important in providing you with a checklist, so that you know, have I gone through this yet? So what you can do in your own department or among your friends is create a single A4 page checklist, including main points from this. Okay, what should you have? What next? How do I pursue this? Okay, so this is what it is. So it's very simple. Again, all of these are considerations that you need to put in. Intervention. This is definitely within the field of surgical colleagues, ONG. Yeah, because sometimes an abnormal or an atypical intervention, the way you hold your forceps slightly differently, is quite difficult. You know, however unbelievable that may sound, that's quite difficult. Okay. So patient perspective is something that we seldom write. Patient perspective is something that we seldom write and has a lot of purchase among the viewers. If you can put in a patient perspective, and sometimes the patients are themselves healthcare professionals, that has a lot of purchase to reviewers. The reviewers would love to hear your point of view. Okay? Why? Because reviewers know, doctors being doctors, you're full of yourself. You know what that means? Full of yourself. You think very highly of yourself. You want to say to the others as if you are the king of the world. You understand? That's doctors. Okay? But what reviewers want to know is not what you think about yourself, it's what others think about you and the way you manage the patient. Okay? Understand? So these are the things that you can put in and checklist as you go along. Okay, so now, once you've decided you want to write the case report, at the very beginning, once you're starting writing the case report and about how a 25-year-old person come into ED one night, feeling unhealthy, presented with low BP and also crashing heart rate, while you're writing this up, you should already think about where you want to publish. Okay? And how you want to publish it as a full case report, 1,500 words, or a clinical vignette. Clinical vignette, barely 50 words, 100 words, 150 words. How are you going to put your case with everything that you'd like to relay to everyone that you're trying to reach out to into 150 words? It's an art and on its own. Okay, so you must know how to. So that's why I say, whenever you're starting out, always start out with a format. And the format should be a full-length case report, which is 1,500 words, always. And then from then you then taper and manage and fit into the clinical report based on the journal that you're trying to publish in. Okay? Images in whatever. Images in radiology, images in medicine, images in pathology, images in ONG, images in ENT, whatever images that you might find. They're usually the best and easiest way to get published. Why? It's usually the image that gets published. And on the clinical case. That's it. And the image gives you a publication. And how many images we encounter? Hundreds, thousands, daily. Okay? Next, okay, I'm not sure why it's not moving. Okay, here we go. Letter to the editor. Okay, now this is up to you, whether you initially start out with a letter to editor or the journals give you the direction. Sometimes the journals think that your paper is good, but they can't publish it as a full-length paper because they think it's got loopholes in it. You know, you can't explain the fact that the total white is high. You can't explain the fact that the chest X-ray shows a lesion up in the upper apical lesion. You know, there are some things that they find holes into your paper. So, but they like to publish it, and so therefore they say, would you like to be able to put this down as a letter to the editor? Do not say no. When they say, would you like to do this? It means they've already accepted your paper. But they want you to rehash it into something that they can then present in their journal. So if you start acting all high and mighty, no, if you don't want to take me, I don't want you. If you start acting all high and mighty, all or nothing, that's it. Don't expect to publish anything in any near future. You must be flexible. Like I said, always start with the full format, 1,500 words, as many images as you can, as many references as you can, as many authors as you can in multiple disciplinary subspecialties, and then they will then give you the direction. If they like the paper, they say, oh, do this and this and this and this. But sometimes I hear from my co-authors, they get depressed. Why? They comment about the English, they comment about the content, they comment about this, they will give you a whole page or 2 pages worth of comments. Not enough 1 page, 2 pages on your single picture. Believe me, when they do that, that means they want you to improve. They want you to publish. They think, they share your point that it's publishable and exciting, but they just cannot understand why you're not writing it well enough. You understand? So don't get depressed when you get 2 pages worth of comments. I've had some of my co-authors up in tears, 7 days not seen in Kuliah. Wallowing by the beach about people commenting about their English. Don't. That means it's good. You're getting good comments. You do it the way I do. I always send to a higher impact factor paper first. So, for example, we've got so many different, quarter type of impact factor, quarter 1, quarter 2, quarter 3, quarter 4. I don't send to quarter 4 first. I send to quarter 1 first. And it's not because I am delusional. Okay? Very easy to think that way. I may look delusional, but it's not because I'm delusional. Because when you send to quarter 1, the ones who are really reviewing are really the ones who are teaching. Senior professors, people who've got white hair flowing down to their buttocks. No, honestly, these are the people that are reviewing in quarter 1 journals. These are the sort of people you want to get an input from. So what I do in my megalomania, I send to quarter 1 journal, I get 2 pages worth of reports. Once I get 2 pages worth of comments, I then gleefully take an ice cream, have an afternoon day off, and then come back the next day, I start writing. Take into account all the comments, and then I send to a quarter 2 paper. You understand? MashaAllah. See? They try to make me depressed, I'm making them depressed. Okay? It'll be your bad luck if they also review the second paper. Okay? But even if they do review your second paper, they see that you're trying to improve. You understand? Okay? So never be afraid and do not be depressed of looking at comments. I always send the quarter one paper. Always. And I can prove it to you. Always send to quarter one. And then when I got the comments, 2 whole pages, very happily, gleefully writing away, improving based on their comments. Sometimes I don't move away from their comments at all. I just incorporate, copy, paste, copy, paste, copy, paste, rehash, paraphrase. And then once it's ready, send to quarter two. Quarter two, what do you think they say? MashaAllah, wonderful paper. Not me who did it. It's the quarter one guys who wrote it. You understand? So there's an art to doing it. You just have to have effort. Okay? There's an art to doing it. You just have to have effort. Okay, so let's move on. This is exactly what I was talking about just now. Okay, whenever you're thinking about publishing, once you've got your own format, your own formatted full case report, then you start thinking about where you want to publish. The things that you must think about: local versus regional versus international. Always easier to publish in local, like IMJM or MJM or whatever it is, Malaysian papers that you have. Always easier compared to regional, for example, Singapore Medical Journal. Okay, very high quality regional paper, journal, or international. I mean, why stop your pneumonia anywhere? Go further up, climb Everest if you have to. Okay, go for the highest. And you know you're going for the highest for a reason. You're not going for the highest because you're delusional about your capability. Okay, you're going because you want comments. Understand? You'll be itching to get the comments. Go for general medical or subspecialty. It's harder to publish in general medical than it is to publish in subspecialty. Why? Because no one else reads subspecialty except your field. Okay? But general medical, everyone reads. That's why higher impact factor. Okay? So local, lower impact factor, international, higher. General, higher impact factor, subspecialty, lower. Unless it's a very sub-specialized, recognized as a super specialist. For example, Journal of American College of Cardiology. My field, very high impact factor. Everyone wants to publish it there from all subspecialties. Okay? They'll try to find a link between their toe and the heart, just so that they can publish it. Okay? I'm not kidding you. I found these patients, or rather these papers. Okay? So open versus restricted access. Again, easier to publish in restricted access. Why? Because they usually mean you have to pay. So easier to publish in restricted access compared to open access papers. Okay? For example, how many of you have published in BMJ, British Medical Journal? How many? None. It's an open access journal. Medical students read BMJ. Medical students read BMJ. Everyone has access to it. But no one publishes in it. Why? So difficult to get in. Okay? And number 3, publication fees. Back when I was publishing and I was at your level, the university actually pays for publications. Okay? Nowadays, tough luck. I don't think they pay for it. Do you? Do they? No? They give. How much? 5,000 per paper. 2,500 for one paper. هذا مش معقول. I did not. So kuliah pharmacy
I paid first. I paid 4,000.
So are there any vacancies in kuliah pharmacy? Kuliah of medicine, back when I was publishing at your level, I think they gave us what, 500 ringgit? Something like that. 500 ringgit at the most. That was then. But now I don't think so. They've run out of banks to go on.
Postgraduate students have bench fees.
Bench fees.
Research bench fees, you can pay for that.
If your supervisor allows it.
Yeah, they don't do it.
Okay.
But it's a fund like postgraduate officer.
Okay.
Like for
So good on you. You should try and do that because, on average, you need to spend about 5,000 US dollars a year. That's why people overseas get published. Not because they're smart, not because they're good, because they've got money. That's all. And they're friends. This professor is friends with that professor. Look, you scratch my back, I scratch your back. It happens all the time. Okay? So make friends. My point is always make friends. Don't sit in silos saying, oh, no, you don't come here. Stay there, I stay here. People who do that are trapped in their own silos and never get out. Okay? Make friends. Okay, so the do's. Always. Okay, so once you've got your paper, you started writing up, you've got your full paper, 1,500 words. Wallahi, when I start my papers, I usually end up with 3,000, 4,000, 500,000 words. Why? Because I want to put everything in there. Everything, including the kitchen sink. Everything I want to put in there. And so what happens is that I've had to cut them down at the end. So just put up everything because you might miss an important point. Okay, you might miss an important point. So just put up everything. So 3,000, 4,000, 5,000 words, doesn't matter. But don't waste your time otherwise. Don't waste your time. And once you've got that, then you skim through the internet and look at the papers that you want to publish in. So this is the question that you ask yourself just now. Okay, where? Okay, so now that you've learned from me, you don't look for regional papers. You don't look for subspecialty papers. You don't look for restricted access. You stand straight to the top. Okay, international, general medical, open access. Why? Because you're looking for comments. Okay, excellent. You've learned something. So once you've decided where you want to send, so this is not the first one. This is the first high megalomania level general quarter one. Once you've got comments and you've rehashed your paper, then you think about where you want to send next. That's the quarter two paper. The quarter two paper now, then you have to list. Give yourself a list, maybe 10 different papers. You then look at the papers, at the journals, and rehash your paper according to the format that is required by the journal. So 10 different papers, 10 different journals, use your same paper that you've modified based on quarter one reviews, and then you try to fill it in. Because different papers, different journals have different referencing styles, different abstracting styles, different way in which they format the papers. And so you use, okay, maybe 10 is a bit too much, 3 or 4 or 5. Choose the journals. Okay? Yes.
The very beginning, they will ask you, our fee to publish is 40,000 ringgit Malaysia.
Look at that.
Let's say
Get
the
by a
paper
lot.
get accepted, okay, kita tahu lah, maybe 90% rejected, 10% chance of getting it published. What if it gets published and like we don't have the 40,000? Is it okay for us to withdraw?
Sell it off. I'm sure you can sell it off. I know what car she drives, that's why.
But this is the baby.
Okay. I get this. True story. Her car is bigger than mine. Okay, and I've been out in the private practice for 5 years. Anyway, what this says is, if you're happy to have your name in the Journal of Nature, what would you give to get your name out there? If your paper is of such good quality to be accepted by the Journal of Nature, would you just stop that just because you can't pay for it? I'm not going to sell my car. I'll sell my son, children, everything, just to get my name there. Now I'll do that. I'll sell my limb, my kidney, just to get paper published. If I could. Nature. Okay? We're talking about one of the premier papers in the world. Okay? So, look, I understand where you're going with this. 40,000 ringgit is a lot of money. But you know, people who publish in high impact factor journals make that sort of sacrifices. Okay? Yes, they do make that sacrifice. Oh no, you wait for the university money, you'll be 6 foot under before you get anything done. Please don't quote me on this, okay? Otherwise, I have to explain myself to Prof. Jamal downstairs. Look, if you were to publish in Nature, not only you become elevated, your university, your department, pass around hats. Even your friends. Or I was friends with this girl. Or she was my student. People are very happy to say you are this and you are that. You know, your university would love to pay for your publication if they could. Unfortunately, they're paupers. Okay, money is elsewhere. So that sort of thing. So to me, if you got a chance, pay. But it has to be a high impact factor journal. Don't pay for a quarter 0.75. That means you're being scammed. Okay? There are a lot of predatory journals out there. Okay? Do not get scammed. And Bells, which is the premier repository of the names of all these predatory journals, have been taken off online. Because the predatory journals have clout. They have political will and they have money. The website that lists the number of and the names of all predatory journals have been taken down. So you don't know. And I'm sure all of you get messages in your emails inviting to write. Scammers. Of course, you get paper published, yes, but you will not be recognized. Okay, so don't. Okay, so check the scope of the journal, find out how to write in that particular or specific journal. Always check the author's guidelines. I have some of my colleagues who just write that 1,500 words and they thought, hallelujah, this is the end of the world already and I've mounted Everest. And so therefore, you accept my paper or you don't accept my paper, I don't care. Go on, no publication. Yeah, don't do that. You must always be humble. Check the referencing style. The referencing style sometimes is the only thing that's keeping you from being published. I've had students who do not get published just because their referencing style is not up to the standard of the paper and they refuse to change. Okay? Do not do that. Proofread the manuscript. When I say proofread, the best thing that you can do is get it proofread by 2 people. Number 1, your senior consultant in the department. Number 2, a senior consultant in the department not related to your department. Why? Because your paper need to be able to reach someone who is a lay person. Okay? Someone who is not in your department. Okay? Understand? So now comes the ethical question. If they read your paper, should you include them in your authors list? If they give you good comments, yes. You're still the primary author. You're still the corresponding author. Why not share? They've given you 20, 30 minutes, however minutes time that they had to look and review a paper. And I'm sure senior consultants in your field have done reviews before and know what is good and what is not. Okay? So don't shy from showing. And don't think that they will, look at your paper and try to, hijack it in some way. They could, but your senior consultants, you know how they are. You think they've got time? Do you think they got time to do that? Okay? So don't worry. Just show it to them, get their input, and if they give you good comments, put their name up. Why not? But if you just tell you, no, go away, find me another time. Then tak payah. Why bother? Okay, right. And sometimes you have to have an English proofread. Okay, English proofread is also very important. Now, some people actually make a business out of this. And is that business legal? Yes, it's legal. So rather than finding someone outside to pay for your English proofread paper, you might as well pay someone like Husni. I have 20%. Okay, he has got absolutely brilliant English. You should use him. Okay, right. So get him to proofread the paper. If it's, I mean, if you're really being nice, put his name up as a co-author. Then he might then publish as well. Okay. So again, check the length of your publication processes and write a letter to the editor. Your letter to the editor must be in one paragraph, able to convince the reviewer why it's important to write for them to publish a paper. So you must sell yourself. You must sell your paper. Yeah. So don't be shy. There are instances where you must be shy. There are instances where you must sell to the highest bidder. And this is the one. You must sell your paper. Okay? Right. So now, what should you not do? Do not rush. Never rush. Because you'll miss out on things. Okay? But if you do have a checklist, then that's fine. Because when you have a checklist, especially as one which is as extensive as mine, you will definitely not miss anything. Okay? So do not rush. Number two, do not completely disregard your author's guidelines. Look up your author's guidelines and write it up. It won't take you long. Believe me, it won't take you long. Submit to multiple journals simultaneously. Please do not do that. Okay, I have had an instance in this university where I have been a co-author and the paper was submitted to two different journals, international journals, and they both accepted it. Can you imagine the sort of letters that we had to write to retract one paper? Very difficult, very painful, and you could get in trouble. Okay? You could get in trouble. So do not again argue with the editors. You get 101 letters, you write back to them who the tooth you are. Surefire way of not getting published. Okay? Do not do that. When you see a review, appreciate it. Change your paper as much as you can to suit the review and then resend. Okay? Resend. Do not argue. And do not disregard reviewers' comments. Okay? Do not disregard. If they say shorten the abstract to 150 words, you say no, 250 is the only way I can relay everything that I need to relay. Don't do that. Why I keep bringing this up? Because I've seen so many people do it. Okay? I've seen so many people do it. Don't do it. Okay, so now, this I'm giving you a cheat sheet. This is a cheat sheet. And this is what we as reviewers do whenever we're evaluating your paper. This is what we're doing. And this is where we look at. Number one, documentation, whether all your paperwork, all your I's and T's have been dotted and crossed, whether all your images have been properly referenced, whether all your references have been properly put into the text. Okay, documentation. We give you a number 0, 1, and 2. Okay, uniqueness, and that is why it's very important for you to write a bombastic letter to the editor. Okay, accompanying your paper. Why? Because that letter to the editor might sway. It might not, but it might too. I've had many letters to the editors sway editors or reviewers on one side and been completely disregarded by another. But because the one who was swayed then convinced the other, my paper got published. Okay, so write an evocative, bombastic letter to the editor, not to highlight yourself, but to highlight the importance of the case. Okay, educational value, very important. Why is it important? Why is the paper? Why is the patient important? Why do everyone need to know about this case? That sort of thing. Objectivity. Okay, show them that you've gone through the whole list or the whole myriad or the whole milieu of differential diagnoses. Show them that you've gone through that systematically. Okay, that proves to them that you've been extensive and exhaustive in your investigation. Okay, and then your own interpretation, your own points of view, and this is where your opinion counts. Okay, this is where your opinion counts in the discussion. In the conclusion, you write your point of view, and that's where you then become more important than just an opinion. Okay, because this is a reviewed opinion. Okay, understand? So this is a cheat sheet that we have as reviewers. I have done many reviews, and these are the sort of things that we look at. Okay, so 9 out of 10, if you've got 9 out of 10, when I say 9 out of 10, meaning what? Meaning, does it come out? If I say 9 out of 10, that means most of your points are here. Okay, 2 marks, 1 mark, 0 mark. So if you've got 9 out of 10, 9 or 10, that means you've got all 5 points, number 2. Okay, so this means your paper hot. Frost. That's your paper. Okay, everyone wants it. If you've got 6 to 8, that means at the very least 3 of these points you get 2. Maybe 2 you get here. Okay, we can use that. Yeah, thanks. Yes, so okay, so if you got 6 or 8, that means so that means 3 out of these 5 you have met the criteria, and that means publishable, but maybe some papers, maybe some journals, maybe not some others. Okay, but publishable. And when you look at reviewers' comments, that 3 pages of those bombastic words they're trying to bring you down, make you depressed, they are bringing you from here to there. That's what it's doing. And when you get reviewer comments like that, that means they appreciate your paper. If the reviewer comment is, your paper is not, what do you call that? It's not, has been reviewed, your paper has been reviewed and has been deemed not suitable for publication. That means it did not even reach a reviewer, it's the clerk who did it. You understand? Why? Sometimes just because of referencing styles. You understand? And then you completely lose the value of your paper. Okay? So that's why pay attention to the journal requirements and always comply. And when you get a long, lengthy paper, review feedback, it means your paper has been read. The reviewer believes that it's publishable. Maybe not in his journal, but another journal certainly. Sometimes they even give you ideas where to publish. Sometimes they give you ideas where to publish. Okay? So therefore, do not irritate your reviewers by sending off emails and saying that, I don't appreciate your point of view. Okay? So whenever you get reviews, it's to bring here to there. Okay? Understand? It's a very important cheat sheet. You can get access to my PowerPoint at a cost. Okay? Some of that cost will go to the Kudia. Okay. So, okay, now we've waxed lyrical. We've talked a lot about, how to publish papers, what sort of formats, this and that, everything. We've done that. So now what I'm going to do is I'm going to give you clinical vignettes, examples of how I did. Okay, so how I did it. So I'm going to touch on three different things, and they are escalatory. That means from one to another, they are getting better. Not because I am better, but because the reviewer comments so better. Okay, and so therefore the journals that I'm going to put to you, there's three. There's three papers that I published. Three of them are from a lower to a higher impact factor journals, and finally reaching the clean alternate. Okay, how many impact factor was your nature? 33. Okay. Let's see. Okay. What?
You can use that pointer.
Oh, okay. Oh, I can use this pointer too. Oh, I see. So well published, so technologically blind. That's how life is. Anyway, so okay. Dry eyes, ENT. You see that all the time?
No, ophthalmologist.
Ophthalmologist. We've got ophthalmologists here too. Ah, okay. So dry eyes. ENT also
We
see.
see it. We
You-
defer to ophthalmology for that.
I've been in this field long enough to know, okay? All right.
Different private sector.
Okay, so dry eyes, extremely common. Everyone gets it, yeah? What about carotid swelling?
Nothing unusual.
Nothing unusual, right? You see that all the time. ENT, mana ENT? ENT, carotid swelling. Yes, right? You get that all the time, don't you? But what happens if you get dry eyes with carotid swelling?
Sjogren's.
Okay. Okay, now I was just trying to highlight by saying now that's uncommon. Whereas he did that in one answer. Dry eyes with carotid swelling, very well, quite rare. Okay, Sjogren's not particularly among tropical countries. Okay. Wait, suddenly DNA, double-stranded DNA positive. You got dry eyes, you got carotid swelling. Suddenly, when you're doing the review of the blood test, DNA positive. No one ever looked at it. So what is it now? So what is it? So it's systemic lupus erythematosus with secondary Sjogren's. Nampak? This was one of my case reports when I was doing rheumatology. Okay, and my consultant was in Putrajaya, so she never had time to write. So I wrote it up because I thought it was an interesting case, and I put it by her, and she said, "That's very interesting." Okay. So your consultants are there to put you in the right direction, not necessarily to help you write a paper, but they gave you that idea, and I wrote it up. So you've got keratoconjunctivitis sicca, which is dry eyes. Just another way of saying it. Okay, you've got primary Sjogren's. Suddenly, with a positive ANA double-stranded DNA evolving into SLE with secondary Sjogren's. How rare is that? Among tropics as well. How rare is that? Okay? Extremely rare. And that was published. This was the first paper I published as a case report while I was doing my master's. I haven't graduated yet. I was still a master's student. First paper. Singapore Medical Journal. Can you believe how many times I had to write back to them? Send, review points, come back. Improve the paper, send back. Come back. Send back, come back. How many times? Okay, can you imagine how many ice creams you're going to finish? Yeah? How many bars of chocolate to finish? Just by being depressed every time? No point, wasting your time. A lot of time. And I thought my English was good. And they came back with your English is not good.
Being Singaporeans.
That's right. Singaporeans, they're so full of themselves. Anyway, so look, that's what it means. This is what publication is. Patience, grit. That's what you need, okay, to publish. But look, from a simple dry eye to a carotid swelling, suddenly you've got a full paper. Okay? So do not discount the cases that you see every day. Okay, and I know for a fact all of you see extraordinary cases. You just don't know how to write, or you just cannot identify the uniqueness in that aspect. Okay, let's move on. 29-year-old Indonesian with fever. What? Every day, isn't it? Yeah, primary care, family medicine, every day. Yes? 29-year-old with fever. Panadol, send home. Okay? Unusually breathless. 29-year-old, fever, unusually breathless. He was chuffing in front of you. Okay? ECG. You had the bright mind to then decide whether or not to do an ECG. Suddenly you see this. What do you see? What do you see? Come on, don't tell me you can't see that. That's right. Look at that. Look at that. Everyone sees that, yes? Please don't tell me that's normal. I would have failed 1,000 years. There's a song, right? T inversion, okay? T inversion, you all see that, okay? I think even a medical student should pick that up, okay? Right. And then, so your ECG is not normal. This 29-year-old, previously well, unusually breathless. You look at the ECG and then you say, okay, all right. So you had the presence of mind to, okay, let's do the chest X-ray. Don't tell me that chest X-ray is normal. Okay? Please do not do that. Okay? ONG, don't tell me it's pregnant. Okay? Look how big that is. What do you think that is? What do you think that is? Pericardial effusion. Okay? So your next step would be an echo. So anything on echo, huge. Look at that. Huge. That's all fluid. That's all fluid. That's all fluid. That's the heart. Fluid left, right, and center, everywhere. 29-year-old, fever, breathless, huge heart, with huge pericardial effusion. What's your primary diagnosis? Myocarditis, perimyocarditis. So infective cause, yeah? Infective cause. So what are the infective causes that you know of that can cause this? Typically in Malaysia. Dengue possible? Anything else? TB, yes, maybe. Anything else? Infective? Viral fever, can it cause this? Yeah, some viral fevers. Yeah. That's right. I mean, everyone seems to associate everything with COVID nowadays. Can COVID cause this? Yes. I got pain in my toe, COVID, vaccination 2 weeks ago. I get that all the time. I get so depressed seeing these patients sometimes. So anyway, shall we angio him then? You'd think that there's probably something wrong. 29-year-old, angio turned out normal. Well, you'll just have to believe me when I say it's normal. Okay. Because sometimes there are patients who come in with acute myocardial infarction and they get restless syndrome. Okay, so 2 weeks ago, maybe. Okay, so it's always possible, especially with that sort of ECG is now the issue. 15 version. But you know, the fever is a dead giveaway. Coming with fever is unlikely to get right. All right, but restless syndrome is real. It's inflammation. You get fever, yeah, and you get perimyocarditis. Okay, so all normal, and then you suddenly dig up everything in the notes again because you may have missed something, right? Published. Clinical pathology. Okay, letters to the editor. I wrote to them as a full paper, 1,500 words. I satisfied all their criteria, and they came back to me. We do not feel that your paper is suitable to be published as a full-page report. If I were to finish there, I'd probably just then shove the email into my spam. But I read further down. However, if you would like to rehash your paper as a clinical letter to the editor, we would be very happy to publish it. many words is that? 2 paragraphs. Barely 300 words. Barely 300 words. But reference publication. Okay? And don't be afraid to publish outside of your area. I find 2 areas where I would be very happy to incorporate someone else from that area and to publish because I know I've got good data and numbers to publish. Pathology papers and radiology papers. These 2 always look for them. Why? Because they are very easy to publish. All you have to do is show a nice image, show a nice, who was from pathology stuff? You were from pathology, yeah? Histopathological slides. Extremely exciting. I slept through my whole pathology course in undergraduate medicine. So, so did everyone. In fact, I failed, yeah? I failed my pathology course. I had to stay back 1 summer. That's how life is. Eh? But you know, publishing in pathology, a cinch. As long as you've got a slide, you can publish. I have had at least 5 papers in pathology. Why? Because I dug up the histopathologist from HTAA, teased her all night asking for the slides, and told her I'll incorporate her as a co-author. And all she did was give me a slide. She gave me a slide, not even an image of the slide. I had to image the slide myself. And that was published. Okay? And the penultimate case. This is the most interesting. 2 women, 29 and 35-year-old, admitted with chest pain. Now, if you are as busy in ED and in family medicine as you are, this sort of women, what are the things that you come to mind? 29-year-old, chest pain. Females. Number 1, you think about, they had a fight with their boyfriends. Number 2, psychiatric issue, call the psych consult. Okay, these are the things that play in my mind. Not because we're evil people, it's because we're busy people. So we try to fit them into a box. Yeah, we always try to fit people and patients into a box. This is the easiest way out. Not because we're evil, not because we're bad, not because we're sloppy. We're trying to fit them into a box. Okay. Unfortunately, when they came, they complain of actual typically ischemic sort of pain. When I mean typically is chest pain on exertion, relief by rest, associated with shortness of breath, associated with palpitations. Typically ischemic sort of pain. Okay? Typically ischemic pain. 29 and 35-year-old females. No respecters. Zero respect. They don't smoke. Okay? At that age, how many of you have got diabetes and hypertension, hyperlipidemia? Less than 5%. Okay? And suddenly you look at ECG. Please tell me what this is. You can come to the front if you want. What do you see? What's obvious to you? Yes, everyone see that. ST elevation, yes? Okay, and perfect. My ENT surgeon has just told me he's got reciprocal changes. So ST elevation inferior plus reciprocal or ST depression anterior.
He was former.
He was formerly emergency. Everyone wants to take credit. You see that? If you were to publish in Nature, everyone is suddenly your best friend. You see that? 64. Okay. That's okay. You're still young. It's still not a dream. It's an ambition. Okay? Now when you age, my age, that's a dream. Okay? Okay, so ST elevation, reciprocal ST depression. Right? Cannot be anything else. This is MI. But why is it happening in these 2 girls? Okay? The question that must come to your mind, why is MI happening in these 2 girls with no respecters? Can you think of any cases that might be like this? Pathologically, you might have you might have vasculitis, vasculitic disorders. Yes, that's possible. One, you might have hematological disorders. Yeah, lupus or protein C, protein S, that sort of thing, deficiencies, that sort of thing. Possible. Okay, could it be OCP? Use thrombosis, yeah, thrombotic states. Possible. Less likely, thrombotic states, more likely venous system instead of arterial, but again, possible. Yeah. But look, 29, 35-year-old, am I? Okay. So you suddenly, in the middle of the night, looking at these patients whom you just now tried to say that she had a fight with her boyfriend. Now you suddenly feeling the heat. Okay. You wheel her down to the angiogram. Cath lab. No. Okay, you believe me when I say it's normal. Yeah? Normal. There is no thrombosis. So what's happening here? Drugs. Excellent point. What do they cause? Spasm. Vasospasm. So they have spasm. They get sudden occlusion of the blood vessel, ECG, chest pain, troponin rise. But after giving medications, maybe some, vasodilators, improves. Completely gone. Completely normal. And then you dig up the history, you look at your demographics, the 29, 35-year-old, you notice something common between the two of them. They were both overweight. Is that giving you any ideas? These two women were both overweight. But they're trying to lose weight. And so what do they take when they're trying to lose weight? And we in GP, general practice, family medicine, they prescribe all the time. What? Apa dia? Huh? There's a word for it. But basically, these two women were on phentermine and sibutramine. These two women were on phentermine and sibutramine. They're the same class of drugs. Yeah. What class of drugs? I'm not sure. I don't remember quite as much. But they are a class of drug that does many things. Number one is increase your metabolic rate. Okay. Number two, reduce your appetite. Number three, induce weight loss. Okay, but they are also very nasty drugs. Some of them get cardiovascular problems. Some get morphological changes to their valves. They get MR, DR because of those drugs. Okay, and in these two patients, unfortunately, they both get vasospasm, MR. Okay, 29-year-old whom you discounted as just having a family fight. Okay, suddenly turning out to be the most exciting cases you've ever seen. And people agree with you. They are the most interesting, exciting cases that they've ever seen anywhere in the world. So it was published. Where do you think it was published? Impact factor 54. Okay, a bit less than your nature. Sure. Okay, that's how old I am. Thank you very much for reminding me. Again. Okay. So look, interesting cases come your way all the time. It's really up to you to, number one, identify it. But sometimes when you identify in passing. Interesting. Betul-betul busy. So inventory lah, patient sebelah muak lah. Kan? So many things that happen that distract you from that case. Faham tak? So what you should do is take note. And sekarang you take note so easy. What do you need to do? Take your handphone. Ambil RN. Click ECG. Click chest X-ray. So easy. And yet in here you've got your cat, your flower, your bird, your duck, everything except this. Okay? So easy. And then as you're cooling down after a busy shift, hash it up. Have a look. Read again. Find out what you need to know. Okay? If it's vasculitis, tengoklah ANA, ESR, double stranded DNA, this sort of patient. If you think this is a hematological disorder, have a look at the platelets. As easy as looking at the platelets, coagulation profile. Senang kan? Simple lah. Simple. Okay? And if you think that this might be related to drugs, ask a proper drug history. Have you taken anything over the last 2-3 days? Are you trying to lose weight? Now that's where your clinical acumen is very important. Okay? And these things can only be taught by experience. Okay? And who's the expert in this field? Who's the expert in family medicine? Me. You. Who's the expert in ONG? No, I'm the expert. Who's the expert in emergency medicine? Stoic faces. You guys should lighten up. Okay? Understand? You are the experts. But I can tell you whether you're heading in the right way or the wrong way. Okay? I can give you ideas where to publish. I can tell you which aspect of your paper that you can highlight. And so therefore, which journal type you can publish in. Pathology type, radiology type, general medical type. And that's what gives me, that's because of my experience. Okay? I have had a paper sent back 7 times before publication. Okay? Not enough quarters to be included. From 4 down to 3 to 2, 1, 0.5, 0.1. So many quarters down until finally it was published at the 7th attempt. Can you imagine how long that took in terms of time? 1 year. 1 year. And yet you cry over a single reviewer saying your English is not good. How can you get published? Okay? Understand? So you need grit, you need determination, you need patience, but you also need to know how. And I'm telling you how. Okay? Good. That's it. That's the end of my talk. Now, if you'd like to show me papers, I'd be very happy to screen to you. Yes. Yeah.
Some cases, you see that they use case reports as either original article or review article. How do we make our case report as that, or should we just focus on a case report?
Now, a case report, by nature of its name, is just a single report of a single patient or a series of few patients, usually less than 10. If, for example, it is more than 10, it's no longer a case report, it's an audit. And so therefore it should be a full-length paper. Okay? But a full-length paper focusing on an audit. But audits nowadays are also no longer in the rave. No one wants to publish an audit unless you have what we call nowadays the better or the bombastic name for audits, registry. And registry really are audits, internal audits that you do all the time. You look at your paper, how many patients cardiovascular come to see clinics, how many of them are on metoprolol, how many on beta blockers, it's just an audit. But from that data, you can then combine with other centers and you can see trends. Okay? And when you see trends, you can publish as a registry. Okay? But how many of you have friends in other places that want to share data with you? That's why make friends. Okay? Break out of your shell. See everyone. Okay? Because you need your multidisciplinary friends to help you publish. Okay, understand? So you've got registries. So that's one. That's shall we say, a more bombastic version of an audit. And then you've got full review papers. Now, review papers are completely different story. Review papers are either, like I've mentioned just now. Okay, we've got all those things. Let's go back. Sorry, it's going to take a bit more time. Obviously, I don't know how to scroll out. We'll go back to the first. That one. Systemic review. That is the best paper. Why? Because you, as an external auditor of multiple different papers that have been published, you go and audit those papers and you come up with trends. And that's a systemic review or systematic review. And so therefore, this has the highest purchase. If you are able to publish in a systematic review, then you are the expert. Okay, because you have looked and analyzed at other studies and you have combined them together and you've made conclusions out of it. Otherwise, everyone else is below that. Randomized control trials, are we able to do that in Malaysia? We neither have the money, nor the facility, nor the resource to do it, especially not in medical base. Okay. Number two, cohort studies we can do. Okay. Number three, case control studies, definitely. They are only one step above case reports. Okay, case control studies. Cross-sectional studies, this is what all of us are doing. This is what all of us are doing, publishing. Cross-sectional studies. But where is it? Just one step above case report. You understand? So therefore, to get purchase, write 10 case reports, one case control study, or one cross-sectional study. That's it. Understand? So don't aim too high. A lot of us try to aim too high, but some of you have obviously done the right thing and gone into systematic reviews, because anyone can do a systematic review. Anyone can do it. But to be able to do that and publish, they want your credentials as well. You understand? Now, who is this brouhaha trying to publish about cardiology when he's an ENT surgeon? Yeah. So they need to see your nothing to do about you. But they want to see your credentials also. So you must also be a figure in that field. Okay? But from the outside looking in. So you're auditing, let's say, 5 different centers in Southeast Asia. Do a systematic review. Invite those centers as your co-authors. Kan? Nampak? Is it easy to publish? Not very easy. Is it easy to do a study? Definitely very easy. I published in Nature Hypertension. Based on one single A4 paper, one single A4 piece of paper, putting in checklist of differences between male and female and high blood pressure. The treatment, the medications, the percentages, the control levels. I compared male and female, and once I was done in HTAA, I did that in HTAA then, I was quite surprised by the numbers. Females are undertreated. Okay, single A4 paper checklist. Single A4 paper checklist. I then gave that single A4 paper checklist to 5, 6, 7 different hospitals, all of my colleagues, and asked them, would you like to do a study? Give me 100 patients now. Just get them to fill up this single A4 paper checklist. And then after about 3 months, came back, data from 5 different hospitals around Malaysia, same findings. Female prevalence of hypertension is high, but female control of hypertension is poor. And so I then took that paper, took that study, rehashed into a paper, came out with some nice, Jamal knows, nice statistical analysis, sent off a few paragraphs. Lo and behold, Nature Hypertension. Why? Because people would like to know why we mistreat women. It's not that we are actively doing it, okay? But Because we keep one close eye when it's a woman. And it's not a disease of males. It's a disease of females too. You do it to yourselves. Understand? This is what I found in my paper. Okay? So, and so therefore I pay more attention to women nowadays. Is that right or wrong? I'm not sure. I'm sure the women in my life will disagree, but anyway. but that is the example. From a single A4 piece of paper, having colleagues, friends, you have now data, you then publish. Okay? Can everyone do it? Everyone can do it. Okay? Every one of you has watched Ratatouille? Yeah? Every one of you have been forced to watch Ratatouille by your children, right? I'm sure. Everyone can cook. Everyone can publish. Okay? Good. Any papers? You're most welcome. Show them.
Any questions? Azarisman?
Thank you very much. I am asking about many conference asking us to do abstracts.
Yeah.
Just 300 or 250
Yes.
paper. Is it wasting of our papers or can be still for publication?
Beautiful question. Abstracts. Conferences abstracts. Are they a waste of time? Waste of your paper? Waste of your references? Yeah? No, they're not. Number one, if your paper get accepted to a conference, that paper on its own is already a citation. If your conference has got a partnership with an individual journal. So they usually publish their abstracts in the journal. And so that's a citation already. Okay, so that's number one. Number two is, don't write your real paper there. Write an aspect of your paper. Okay, and don't write your full title there. A study on male-female interaction in regards to hypertension study. Don't write that. Write something else. Write, for example, a review of hypertension control in Malaysia. Write to another conference, a review of hypertension control in Pahang. Write to another conference, right? Review in the hypertension control in whoever it is that partnering you. One time. You understand? But it's the same data. But different title, slightly different aspect of the abstract. Your full paper, you write whatever it is. So now, from that one single paper, how many citations do you get? 4 conference citations and 1 full paper. Understand? And you get to holiday to 4 different conferences.
Really, because I published a lot, but I think that
Look,
yeah,
abstract publications are cited, but they don't count so much.
yes.
Okay, they are there to populate your CV. But it also helps if, for example, your abstract has been found strong enough to participate in a category for, say, for example, young investigator, or a review study or something, whatever. Then that has merit. Then you should put it up. It should count for minor point. It should. Okay. So you must look, whatever it is, even in publication, you must go towards a publication, towards a conference or towards a journal with a publication in mind. You must have that. And so therefore, if you're thinking of publishing and populating your CV, send to 3, 4 different conferences, making them reputable references. Don't send to one-time medical center or something like that, but send to a reputable conference, get a published citation, and then use that published citation then to populate also your letter to the editor. You remember, you're writing a letter to the editor soon about how they should take your paper and accept it. And then you can write that down at the end of your letter to the editor. These papers have been published in conjunction with my full paper and have been put up for young investigator. Oh, for every published abstract, that means it has been reviewed. You understand? Even though it reviewed in passing, it has been reviewed and accepted. And so therefore, when you say in your letter to the editor, please do accept my paper, it has strong merits based on this, plus it has been accepted and published as a citation in 4 different conferences. And they will then be more inclined towards accepting the paper. Look, this boy is not just, waffling. He's got a real paper, real study, published multiple conferences. Understand? Put strength into your paper. Okay, so it's not just about holidays in 4 different places, but but that's part of it.
And it doesn't look like breaching the
No,
but
as long as it doesn't share the same name.
okay.
You understand?
Must play with the title.
So you play with the title to write about a different aspect of your paper. That's not your paper. Has so many things that it's commenting on, and so every aspect that you're commenting on, one single paper. If you think that breaches, ethics, then you should look at engineering papers. They come up with one equation and formula. They run a series of theoretical formulation and analysis, publish that as a single paper. Just by changing an X on their formula, changing an A, an alpha, a lambda. On one single universal formula, they publish, if you've got 20 different alphabets on your formula, 20 different publications from one formula. That's what engineering does.
And it still can, if it is a case label, still can be a different view about the case.
Yes. Example, look at my case report. The females with an MI. I could have highlighted, for example, the fact that sibutramine was in their blood. That goes to a pathology paper. If then I highlighted the fact that it was an MI with normal coronaries, I can put that up as an interventional cardiology paper. 2 different aspects. Same case. Understand? So we need to be a bit more imaginative in the way we approach papers. Okay? And playing around with words is not wrong as long as ethically you know what you do. Okay.
Thank you very much. I keep aside many literature for me.
Exactly.
Thinking I cannot reuse it again.
It's a waste.
Good advice.
It's a waste.
Thank you very much.
Okay. All right. So any example? I still haven't seen example papers yet.
Oh, yes, sir. Yeah. And that's what goes to the each person's table, or we're gonna put up the case report up here.
Oh, okay. Up to you guys. If you're not shy, you can put it up here. Then we can all reevaluate together. Look for the comments. Remember what I tell you? Don't be afraid of comments. Don't be afraid of. Yes, please. Go ahead. Okay, so we'll put it here, is it?
Yeah, I think really want to talk. I think
Yeah.
see what
Or
we
you
have
can
here.
bring your laptop and connect it up to the HDMI. Yes, I'd like to see what you guys are up to.
In the meantime, Prof, I got a question actually.
Yes, yes.
Like how important it is to have a co-author who's reputable or known in the field itself.
Okay.
Does that make a difference in terms of publication?
Oh, yes, absolutely. Why? Very important for you to have co-authors that are recognizable, reputable. Why? Because number one, you have to understand, your reputable professor has got friends who are reviewers. Okay, that's number one. So that's what we call journal diplomacy. Okay? It really happens. It does. It's bad, but it does happen. So that's number one. Number two, if you notice, especially randomized control trials in medical papers, you've got a whole list of names. The one at the last is usually the most important. So this is how we differ from, let's say, social sciences. Social sciences, 1 or 2 authors. The most important is the one in the front. In medicine, the least important is the one in front. You almost always know they are usually fellows. They are doing the dirty work of writing papers. Okay? The correspondence or the last in the list is usually the senior physician. Yeah. So, well, sometimes maybe pharmacy it's slightly different, but I think it's about the same scientific papers.
Yeah, clinical, yes, but in IIUM they want.
So Myra, they want number one or corresponding
First,
author.
no, like the earliest.
Yeah.
If like we are like 3 or 4 from IIUM, so the first one who's mentioned will take the highest credit.
Yes, but you know that makes sense also because he did the most work.
Might be like number 2 or number 3. Get the highest.
Number one is usually the one who does the most work. So he merits to be mentioned and merits to be recognized in Myra. Yes.
What about let's say an author? Is the same person who is the first and corresponding author?
That's just plain selfish.
Let's say if you share to put somebody else's name,
Hmm.
would that reduce the marks that you will get or if you're looking something?
No, in terms of Myra, you get acknowledged as the first or the corresponding author. So I think it should we as lecturers who are trying to teach people should number one, first and foremost, give out good example. Okay? And so therefore, the person who merits the most recognition for writing up the entire paper must be number one. Must. That's ethics. And then you, as the principal investigator, or rather the principal supervisor, can then become the correspondent. Oh, so you get your own. Okay? But don't be, don't put your name up as good. Now, I do know of instances when I was deputy dean of some of your senior supervisors insisting that their name be a corresponding author because he was a head of department or because he was a senior professor. That is just plain wrong. That's unethical. Wrong in every culture and religion. If they insist on doing that and they tell you to do it, you can come by to the office of deputy dean academic because that should be stopped. That's unethical. You do not have a right to control the publication when you're head of department. Okay? Now I might get in trouble this the last time you see me. So let's see how what goodbye is properly.
Are they the first? So should we go through?
Okay, sure.
The first
Right.
is for the
Okay. So please don't fall into that trap. Be gracious. Yeah. Everyone we share. Everyone shares. Okay, so let's go. Dilemma in management of concurrent pelvic organ prolapse and ovarian mass. We are talking about the female organ here, yeah?
Yes.
Oops. Okay, so concurrent pelvic organ prolapse and ovarian mass.
Basically, they have prolapse.
Mm.
But most of the time, we manage prolapse on its own. So rarely, if women of postmenopausal age, then they suddenly have ovarian mass. So prolapse surgery are mostly vagina. So when you have something up there, the ovarian, the operation route is debatable. So this is what I'm trying to bring. Because we had a case where she had concurrent, and the nature of the mass is also suspicious towards malignancy. It's benign, malignant. So the decision for the type of surgery for pelvic organ prolapse and in urogynecology. So this is the area I'm dealing with most of, not the mass part. So the decision for surgical option.
Okay. Whether surgical intervention meaning what? Meaning from
Transvaginal, abdominal, are you using mesh? Are you using maybe tissues?
Okay, good. So looking at the title, I know already that's what you're getting at. Approach, top or bottom, and then possible complications. Yeah, but it would be best if you could have shown us your abstract first. Where's your abstract?
That's it, bro.
Okay. All right. So your abstract would have given me the perfect idea of what you're trying to get at. Okay. So always, like I said, whenever you're starting a paper, don't start, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Start off with the case report. And then number 2, start writing your abstract because that will then reorder your mind. What you want to write, what you want to highlight. The abstract is the one that does it. Further. And so therefore, when you're writing up the rest of it, the discussion, the conclusion, you are kept in check by your abstract so that you don't go rattling off in tangents. Okay? So have an abstract first. That's my idea.
Write the end case report. Memang tulis je abstract. Apa idea kita tu.
That's the synopsis of what you're trying to convey.
And then expand.
And then,
Rather
as
than
you're
writing the
writing
whole thing and summarizing it up.
that's right. And then when you read your own abstract, you say, interesting. You sold it. If you read your abstract, maknanya you won't find interesting macam mana? Kan? You can't expect anyone else to win. And believe you me, whenever we are reviewing papers, the first thing we look at is title. Number two, abstract. Because why? Reviewers are lazy. They don't want to read your whole paper. Yes. I'm not meaning anyone else apart from me, okay? Don't get me in trouble. Okay. So reviewers are absolutely lazy. I mean, how can you read 1,000 papers? Yeah. So they read your abstracts. And so your abstracts should be the gist. Right at the very beginning, first sentence, this is to show that delivering this baby from the back is better than from the front. Something like that, okay? Don't quote me on that, but that's what I'm meaning. Okay, so your abstract, your first sentence in your abstract should be the wow point. Okay, and so if you were to show me your abstract and with the wow point, I can then evaluate your paper based on your wow point. You're going off in tangent here, or you're going here, you're going there. You're not highlighting this. So the abstract that you're writing at the very beginning is the one that tells everyone else what you're trying to convey. Okay? Boleh? Sebab kalau you baca you punya paper ni, within the first, this is usual, within the first 3 paragraphs, you've lost me. You understand? So apa? First kita kena baca dia punya clinical scenario, okay? Regardless of how interesting it is. You show me the abstract, and then I can then refer all the time. When I'm reading this paper, bila ada abstract, I refer to the abstract all the time. Faham? Okay? So don't do it the academic way. Do it the proper way, which is write your paper, title, then your abstract, and put what the wow point is in the abstract, including kalau ada images and everything. Just attach them, or sticky note them to your abstract, so that you then know where to focus. Okay? Good. Good. Itu satu. Nombor 2, dilemma is not really a nice word. Okay? Dilemma is not really an academic word. So let me show you how we can go around it. Senang tak? Easy tak? You don't have to be an English speaker. All you have to do is find another word for dilemma, synonyms. Okay? Now, quandary, that's a nice word. I've used quandary in at least 3 papers. Okay? Dilemma and quandary. I've used quandary in at least 3 papers. Dilemma, never published. Okay? Faham? So, Mak Saleh ni, dia nak nampak eksklusif. Sama macam orang Melayu kita kan. Orang Melayu kita tak cukup. Oh, sorry, I'm blabbering in our language. Sorry. The English, they like to use bombastic words. Okay? They like to use bombastic words. Why? Because, this is very dry. Academic writing is very dry. It's trying to get through the first half of the page is torture. So how do they play? These are smart people, intelligent. So what keeps them intrigued, excited, happy? Play of words. Understand? Play of words. So that's why I say the word in We don't have a whiteboard marker. But the word in English is called piquant. Piquant. Piquant is a description of a nice word as an alternative to something that's usual. So it's not difficult. Synonyms. Yeah. It's not hard. Not hard at all. But you increase the value and publication potential of your paper. Okay? Understand? Okay? I'm not picking on your paper, I'm picking on the title. Okay? Right. So, quandary ataupun what you can write an ethical quandary. Okay? And what you're trying to say is how to manage a pelvic mass that's causing prolapse. Kan? That's what you're trying to say, kan? Betul? Ke salah? Then macam mana? How?
There's two things you try to manage. How? Not one.
What exactly are you trying to convey?
The surgical method that is most suitable when there is for prolapse, when there is another problem, which is ovarian.
Okay.
So down first and then additional of something else. Not
Try-
up first and
Try to
additional.
convey that in a single sentence. Because it's not coming to me. Nampak tak? Okay? So, what you can write is a surgical quandary. Best practice approach to operating patients with
Pelvic prolapse
and
and
easy.
Title please, so long.
Okay, doesn't matter. It's okay. But it's concise. It tells you exactly what you want to tell me. And it's what wondering. Nampak tak? So, today lah. Yeah. Next case report coming out. Okay? A surgical quandary or an ethical quandary. Okay? Approach towards surgical decision making in whatever. Okay? So sometimes the catchy title is very important. Okay? But what makes the catchy title important is your abstract. That's what they want to know. Okay? Okay. Anything else you'd like us to improve in terms of your paper?
ask one question.
Sure.
So for example, when I did, can we suggest, so from this case, we learned that, people are not describing when there are concurrent problems. People only describe the OP punya surgical options. So when we have this kind of patient, it was difficult for us to decide which way is the best. So I put down there's a table that I propose. If
This
so
one.
we
This one here.
should if the procedure involved is this with whatever prolapse. So I suggest the surgery would be which one is the best. Do you think this is suitable for a case report or it's more to a review, like a review now?
Okay, very interesting. You can use the case report to suggest your, what do you call it? Algorithm. Yes, that's yours. That's your point, your opinion. They agree with it, they'll accept it. Tables are not very good in case reports. Don't use tables. Okay, tables are really good for RCTs, published papers, cross-sectional studies. Very bad for case reports. Don't have it. Even if you want to put it up as a table, get rid of the lines. Okay, they need aesthetics. Okay, aesthetics. But what's more important, if you can make that into a flowchart. Okay, so you make it, for example, surgical prolapse, and then left and right, intra-abdominal mass, no intra-abdominal mass. Then how to proceed? Make it that way. Okay, so move away from tables and move towards flowcharts and also algorithms. Okay, good. So
She actually write this as a separate case.
okay, what would be better if you have a case series? Say you have 4 or 5 different patients. I'm sure you get that every day, right? No?
Most of the time, it's postmenopause. They don't get cysts. They only get prolapse. So when they got prolapse, suddenly there's an appearance of a cyst, then it becomes And that's why people don't describe this management.
Okay. So
They
that's the
not really
novelty.
important.
That's the novelty as well. So you're not only just describing an approach to procedure, which is the novelty in a surgical field, but you also, the novelty is the fact that this happens very rarely. Faham tak? You understand? So you can write 2 case reports. Nampak? This is dah mula tamak halu dulu ni.
Perang dan muka.
Okay, look, you can definitely write this. You know why? Because this flowchart could be just in your letter to editor, just a flowchart. Simple brief case report. 1 paper. Absolutely.
But totally because this is your suggestion, kan? The first one you describe your one, and then this is what you suggested based on whatever. You can actually say.
Okay, nampak? And ni lagi satu. This is what we need to change our mind. I'll show you this. What does that tell me? What does that tell me? An ovarian mass, kan? That's all. What would have been better? We collaborate with our pathologist. Show a slide next to it. Pathology slide with impregnated inks. Kan, whatever, showing what. Gambar ni, orang tak ambil dah. Gambar slides, confirm. You can admit this, submit this into a surgical paper, ONG paper, women paper, or pathology paper. And which is the easiest to publish? Pathology paper. Nampak? 3 papers. 2 in ONG, 1 in pathology. Different aspects of the same case. Nampak tak? Have I gotten your mind racing already? Kan? Gila tau jadi. Sebab apa? Sebab you all jadi tiba-tiba tamak haluku. Semua nak buat. Okay? You become so enthusiastic about publishing. All with a single case report. Understand? That's what you must always look for. Because I'm sure you see so many cases. Kan? Look, inshallah, my wife has been pestering me on this one for me to publish a few papers for her MRS. Yeah? Case report, and I promised her half an hour already. She's been reminding for the last 3 months. So it's not only your problem, it's everyone's problem. So it's actually getting down to sit down at the computer and to do it, that's all. But it all starts with the case report. 300-word case report, how long is that going to take you? Not long. But once you've done the 300 case report, 300-word case report, everything will start flowing. Okay? Right. So now, the idea that I had in the past was to have a series. And this was, I actually touched this with some of your colleagues from your other departments as well, is to have a series. And what I do is, in this series of meetings that we're going to have, if you agree to have it, is for you to start off like Hikmah just now, bring a paper, let me comment on a few things, and then you come back in the next series with what I've touched on. 3 different papers on 3 different aspects. You did take this thing out, right? You did take this thing out, this ovarian mass.
Yeah.
And there was a pathological report. That slide is a whole picture images in pathology. Tapi kena your pathologist lain jaga, kan? Gambar ni. Because now you guys ada berapa orang histopathologists? 3, 4, 2, 3. 3 histopathologists. Back when I was deputy dean, 0. That's why I had to chase the histopathologist from my HTA sampai tengah malam. Just to get a slide. Even 2 pun tak dapat gambar, dia bagi je slide. Now, Masya Allah, look at what wealth of, subspecialties you've got. Okay? Try to get a histopathological angle to all your clinical cases. Confirm will publish. And try to get a radiological angle to your clinical papers. Confirm.
Azarisman.
Yes.
Quite short of time actually.
Really?
Yes.
My God, I've been blabbering that long.
Online.
I'm going to stick with these people here. Sebab because there are quite a few people who want to show their case reports.
Oh, okay, please do. Okay, next.
I think the best course of action is actually for you to just go around the
Okay.
room. Is that okay?
Right, who wants to show me a case report? Okay.
There you go. You can follow around.
Okay, now everyone raises their hands. Okay, ice cream for one. One case report, one ice cream. I'll be very happy.
In the meantime, for those of you who want to grab some food, you can just start grabbing the food and boleh makan dulu, enjoy while Dr. Azariman is going through some of it. Juga ke?
Okay, so the paper here is an unusual presentation of papillary thyroid carcinoma that resembles lymphoma. How do you distinguish between papillary thyroid CA and lymphoma? So you've got clinical distinction, how they present slightly different, but what's the clincher? What gives the diagnosis? Your chronic profitable. Okay, so what you need to do really is number one, okay, fine, that is okay, but the unusual presentation of papillary thyroid carcinoma, when you say unusual presentation, you mean clinical presentation. Okay, so what you can emphasize is the clinical presentation aspect. That's one paper. Another paper distinguishing it pathologically, and that's just a slide, a picture. That's it. And all you need to do is show one slide, papillary thyroid CA, second slide, lymphoma. That's it. One up. Okay, and that's where she comes in. Okay, see now, when you show a slide, okay, I'll put this out there. When you show a slide of a histopath, don't show the lowest magnification. Show the highest magnification. Okay, so show. Okay, and if it's got special grades, inks, and things like that, show that one. Especially if you've got other inks of many different colors, green, yellow, black, white. This one not so good. Find specialized ink. Your quality will be exactly, that's the word. Sorry, I've lost my touch. Anyway, so immunohistochemistry. That's what will get you publication. Okay, and show them side by side. Right? So that's one approach. So one is the clinical approach, and you can write that as a paper. The other is letter to editor or images in radiology, images in pathology, showing that, and then in your vignette, in your clinical case, you just write about the distinction on how presented clinically. Understand? 200, yeah, but that's everything. So what you need to do now is then you rehash that, make it a bit more patchy, emphasize on the immunohistochemistry, and then you send to a radiology paper images. So once they see your image, they'll tell you what they like about your paper, and then they'll tell you how many words you need to write. Then you just bring it down. Come on. Okay, simple. So, but this is how you start off in the format. Huh? Again, the full 1,500 words. Okay, but don't think that is going to come there. It will come out in many. Okay, okay, good. Next. Okay, dekat sekali yang sorry. Okay, yes. Topical treatment for tinea capitis. Remind me what that is. It's a fungal infection, neonatal period. Very rare, Okay. What's the prevalence and incidence like? Okay, so you must qualify your statement kan. When you say it's very rare, you must be able to tell me why you think it's rare, because incidence and prevalence rate is very low. Okay, so that number should be in your paper, full paper. Okay. Hmm. 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 Okay. Hmm. Hmm. Okay. So let me have a look at your abstract. What does it say? Tinea capitis is rarer in neonatal period. Okay, so the period itself makes it rare. And then common childhood period. Okay. Presentation may mimic other skin diseases. That's very nice. Seborrheic dermatitis. Okay, so that's good. So how did you come up with the diagnosis? Ah, again. What? Again, same person comes up. Doctor, pathology. Yeah. Ah, so, but, so it's everything boils down to that. So if you've got nice pictures, nice chemistry, ada. Ah, oh, okay. So try to get something about that. Ah, yes. And then if you can show what the different differentials are. Contohnya, this is tinea capitis. What does, like the penis look like under the microscope? Mana? Jadi dia tunjuk lah. So you figure this out by doing that, by distinguishing it from the rest. Sebab clinically you can't tell, can you? It's all just red urticarial rash. Correct? So okay, microbiology and microbiology and also pathology. And so the topic of treatment is the novelty of the treatment. But before you come up with the novelty of the treatment, you must come up with the novelty of the diagnosis. How do you tell the difference? Yeah. So that's one novelty already. So identifying tinea capitis in the neonatal age group and successful topical treatment. Hmm. Yeah. So that's why we nak tulis surat pada orang untuk buat the actual setting apa semua tu, the culture and everything. What is the thing in your mind that makes you think of tinea capitis? Clinically. Kan? So itu yang you have to tulis dalam you punya referral letter or you punya order letter for staining and things like that kan? So that one is the novelty. You figuring it out that this is tinea capitis and it could be 5, 6 different other things. So why is that a novelty? Because of different demography ke, atau their appearance ke. So the animal contact is your clue. So you letak your animal contact in your abstract. Faham tak? So that orang tahu kenapa you thinking of tinea capitis and you've got so many other things. Because you're thinking because the patient has animal contact. Faham tak? So that must be in your abstract. But in your title, novelty of diagnosing or identifying and novelty of treatment. Tak ada. Hmm. 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 You try to boleh lah if you want to list it down, tapi you are listing down case reports, you're not listing down randomized controlled trials. So when you want to put down a list, you don't like this of case reports, you like this of randomized controlled trials stating this, stating this. So kalau case reports, you just list in a paragraph. Ataupun you kata there has been very few case reports, much less randomized controlled trials regarding the use of topical application in patients with tinea capitis in this history. And then you just put this reference, as reference 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Instead of you putting out like this. Sebab apa? Selalunya orang put up slides like this to show points. Maknanya how many patient treated, what is the relative risk, apa improvement, that sort of thing. Bukan sangat nak list the number of papers. Faham tak? Yeah. So you just settle almost all case reports into the treatment of tinea capitis utilizes an oral treatment instead of topical. So then, so it's just like reference 1, 2, 3, 4, 5, 6, 7, 8, 10. Dia masuk dalam reference list. Tapi tak payah lagi buat benda macam tu. Yeah. So even and then you tulis and far fewer case reports explore the possibility of topical successful topical use in tinea capitis. Reference here. Sebab why? Because believe me, don't have to focus on slides. Gambar. Rather than that. And so you can know how to bring down the number from 1,500 words to 250 words, just as simple as that. The only way you can do that, semua jadi sub. Yeah. Yes. And just ada one simple word stating. Atau sorry, simple sentence stating. Alright. So you must be able to move from full length paper, short aspect, full length paper, and backward. Oh, memanglah lain format. Tapi it doesn't matter. Kalau you just put it as reference, doesn't matter. So everyone knows that the editor is actually a case report, but not accepted as a full paper. Accepted as a letter to editor. Whatever it means. Everyone knows that. Everyone knows that. What I put the three most recent. Three most recent. Unless history is what you're looking for. Three most recent. You know, tak sampai 3, 4, 5, 6, 10. Nanti sekarang kalau you buat letters to the editor, dia nak 3 references. Dia nak jual. Yeah. So just be aware. Okay, this is okay. That's good in a PhD. Why? It tells the supervisor or you've done your homework. But in a review, okay, fine. Yes. Okay, next. Yes, come. Okay, what do we have here? Dental condo. Okay, interesting. Cervical fibroid is rare. Qualify your statement. How rare is it? 2% rare. 2% uncommon. Not rare. So endometrial. Okay, right. And so it also cervical is only in 2%. Okay. So okay. So okay, let's go to the next step. Let's go to the next step. Effect ni macam ni kan? Kita tak ada lagi effect. Audio effect. Okay. Okay, so you've done your abstract well, maknanya you describe that well. Tapi look, when you do a case series, you don't do case 1, case 2, case 3, case 4. Not in an abstract. You summarize. distinguished. I mean, looking at it with your eye, you can't distinguish it. Unless it's right in the cervix. Even then, you can see it. You can generally look into going for it. Okay, how rare is that? You must know. Sebab kalau macam ini, then I agree with you that picture should be nice. But you must have at the next to it your histopathological imaging. Okay? So if you think that this is the novelty and you see very few of it, then this picture should be the focus of your title and your people. If this picture is the focus of your title, this is no longer business. It's a case. One case. So what you should do is, then you better you ada three different subgroups tadi kan? In all three different cases. So the novelty here should be, number one, at any presentation subgroup is the same physical picture. Okay, so that's the novelty. So maknanya, regardless of your presentation or regardless of your clinical presentation, that's the same picture. Unfortunately, not everyone sees that clearly. How do you recognize that without invasively setting the patient? How can you see it? You can't sell clinical analysis. Okay, you can show, you can't sell it. But sebab apa? Sebab clinical competence is an art. Not everyone can get it. Everyone aspires to get it, but not everyone get it. You need to be able to teach the poorest veteran about how to recognize it. So how's the best way to recognize something like that? MRI ke, CT scan ke? MRI image the same mata to do it. Not the picture of the uterus. Not the picture of the cervix. Ya, apa lagi? Move away from this. Move away from flow diagram. So your diagnosis, flow diagrams in three different age groups. Same. Then management, treatment, whatever. So but flow diagram, flow chart, not. Okay. Yes. Okay. Next. Yes. Next. Who's next? Okay, come.
So just a reminder for those of you who have grabbed your food, please do so. And just scan the QR code for the feedback form for this session today, okay? So we really appreciate your feedback so we can do more in the future.
Yes. So it's okay, let me get my, is it a telephone? Is it? No, yeah. Okay. Hmm. Okay. Hmm. Okay. How many patients do you have here? This two can be a case report. The way I put my case up, so that is a case report. But they have to have commonality. What's common? Okay. How differently do they present? Okay, so we discovered postmortem. Okay, so in that case, then the normal thing is identifying HDL, in two different conditions. You boleh write case series, tapi because the structures are so dissimilar, so different, so it's very difficult. Macam my commonality was female, older, very common. Kan? Your group, one is unit, the other is adult, pediatric. So what you could do is maybe how do you normally discover if you do they have any particular clinical presentation? Tak ada. Okay. So in this case, then what you should highlight on is the HB